All right, good afternoon. We might get started. Welcome to our second pulmonary session of the program. Good to see that we're in a bigger room, so hopefully the standing room only and people unable to get in, we won't have replicated this afternoon. I'm Paul Roach from Royal North Shore Hospital in Sydney. Sitting next to me is Marika Bach, who's well known, the queen of lung scanning, or the queen of VQ SPECT, I'll call her. So look, the other... VP SPECT, I get into trouble for that all the time. All the Europeans here. So on Saturday we had, I think, a good session where we focused on the clinical side of pulmonary embolism and then quite a bit on SPECT. Today we're going to look at some very different things. We're obviously in the CTPA era, so we're going to start on that one, radiation, pregnancy, non-pulmonary embolus indications. And then at the end I've asked Henry Royal to just sort of get out his crystal ball and give us some thoughts on where he sees the VQ. So it should be in the future. So it should be a good session. Now Henry tells me he's on an 8 o'clock flight to the United States tonight, so we need to keep this session to time. He will be walking out the door at 5:45, he said. So, and the rest of us, I'm sure, want to get off to the gala dinner. Firstly, just if everyone could turn their phones to silent, please, that would be good. So let's get started. So our first speaker is Diane Pascoe, who's a radiologist from Melbourne, Royal Melbourne Hospital, and she's going to talk about CTPA, the good, the bad and the ugly.
Good afternoon, everyone, and thanks so much for the introduction. I'm talking today about CTPA, the good, the bad and the ugly. And as the token radiologist here, that's not working. When I accepted the invitation, I thought to myself, well, gee, radiologist speaking to a group of nuclear medicine specialists about CTPA. This is either brave or stupid. I'm going for bravery, and we'll see how we go through the talk. So things I won't cover, I'm not going to do a statistical head-to-head of VQ and CTPA. That's coming later in the session, I believe. And I won't be talking about the clinical indications, risk stratification or pretest probability assessment that was covered earlier in the previous pulmonary session. I won't have time to talk about chronic PE and chronic thromboembolic pulmonary hypertension, both gorgeous topics, but we can't do it today. What I will cover is what's good about CTPA in acute PE, the CTPA technique and how it can cause problems with the images we produce, and then how we tackle those problems. I'll raise the question, is CTPA just too good, particularly in regard to overdiagnosis and incidental findings? And if we've got time, I'll touch on some future directions. Sorry, this little clicker's not working. So starting with the good, always good to start on a good foot. Even this room would have to agree that CTPA is just so very pretty. We just have lovely images that come out. The clinicians love them because they relate to the way the patient looks to them. It's a sensitive test, as you all know. Pipehead 2 reported sensitivity of 83%. We do much better than that now with newer generation scanners, and most studies would now report in the 95 to 100% sensitivity range. It's fairly specific. It's got a good negative predictive value in low and intermediate risk. So it's also an accessible test. So most major hospitals now would have a CT scanner co-located in the emergency department, which makes transfer and quick scanning of even unstable patients pretty streamlined. It also gives us a lot of information about potential differential diagnoses. It'd be lovely if patients came into the emergency department with PE or no PE stamped on their chest, but they come in with symptoms like breathlessness or chest pain, and they have differentials associated with them. So in this case, a lady with breast cancer who had pleural metastatic disease and a large effusion. Not that you wouldn't pick up the effusion on chest X-ray. It also gives us information when patients are diagnosed with PE about the downstream consequences of the PE. So the clot burden, which we know is associated with patient mortality. We can see the pulmonary hemorrhages and infarcts associated with those. And we can also make predictions about the presence or absence of right heart strain. So in combination with clinical findings and ECG abnormalities, we can use CT findings such as dilatation of the main pulmonary artery, a normal upper limit being about 28 or 29 millimetres, flattening of the interventricular septum, and significant reflux of contrast into the hepatic veins, all to potentially escalate therapy to perhaps thrombolysis or intra-arterial clot retrieval. So I'll briefly talk about the CTPA technique, just so you understand what we do. So the main aim of the game is to opacify the pulmonary arteries enough that we can see the low density thrombi as filling defects within the pulmonary arteries. So acute thrombus has a Hounsfield unit or a density of about 35. chronic clot can go up to about 90. So if we aim for 250 Hounsfield unit, we're always going to see a good differential between the clot and the contrast. Now, there's certainly some literature out there that's supported accepting lower Hounsfield units, good evidence for 210, some emerging evidence for 180. I kind of think of these a bit like 8-minute abs moving down to 7-minute abs. Just because you can do less, it doesn't mean it's necessarily good for you. So I think it's good to expect good quality scans. I like 250. So we start off with a scout view or a scanogram, and we use this in two ways. So our radiographers use it to plan the extent of the scan. So this might be the extent for a typical CT chest, where we want to include the extreme lung apices and the lung bases and the upper abdominal viscera to cover the adrenal glands. In a CTPA, we don't need all of that extra information, and we can narrow down the extent of the scan, sometimes excluding just the extreme lung apices and bases, and in doing so, we can decrease the dose to the patient by up to 20%. In addition, the scan uses that scout view to perform automated tube current modulation. So it makes an assessment of the density of the patient at each individual slice, and then on the fly during the scan will minimise the tube current that's provided at each slice to maintain a certain image quality. So it's another way that we decrease dose. We give the patient an injection of IV contrast. We trigger it based on the main pulmonary artery, a density usually of about 100 Hounsfield unit there. So we get patients to take a submaximal inspiration. That's really important. I'll come to why in a moment, but we don't want them to take a really big breath in. It needs some coaching beforehand. So if the patient's really acutely unwell or they can't comply with those instructions, we'd really rather perform an ultra-fast scan with no breath hold than them taking a maximal breath in. And I'll come to the reason for that in a minute. So what constitutes a good scan? What do we like to see? Well, this scan on the left would be pretty much a perfect scan. We've got a density here of 552 Hounsfield units, so really good, well above 250. We've got almost no contrast in the aorta. We've got very little streak artefact coming from the residual contrast in the SVC, and best of all, no PE. So this is a good one for the radiologist to read. It's nice and easy and a great one for the patient. The one on the right-hand side is also a good scan. So we've got, again, the density of above 250 Hounsfield units, but in this case we're seeing the typical appearance of an acute PE on the right. So a sausage-shaped filling defect centrally within the lumen. It's making acute angles with the vessel wall where it contacts it, and sometimes can even expand the vessel when it's completely occluding it. I call this one a good enough scan. So we haven't quite reached the 250 Hounsfield units. It's sitting at 243. Got a lot of contrast in the aorta, pretty much no contrast coming through in the SVC, but we can still make the diagnosis of PE. So there's a left-sided significant thrombus there, and then lots of other small segmental and subsegmental PEs as well. So then we move on to the bad and ugly scans, and so these are the ones that we don't like to see, obviously, and they usually happen for one of two reasons. One, we haven't got enough contrast in the lumen of the vessel, or we've got artefact that's making it hard to interpret. So in terms of suboptimal opacification, that can happen because we don't give the patient enough contrast. So particularly large patients, overweight patients, and pregnant patients who have an expanded blood volume and hyperdynamic circulation, we need to think prospectively and give them a high dose of contrast to minimise that risk. There's also this phenomenon, transient interruption of the contrast load. So this used to happen in the old days when we had patients taking maximal inspiration. It's a tricky concept to get your head around, but basically when they take a big inspiration, you get a rush of blood into the chest. Most of that comes from the unopacified IVC. You get them to breath hold, that's an essential Valsalva, and then you get no more contrast opacified blood coming in. So you can end up with what I think of as the ugliest of ugly scans, where you've got contrast coming still in through the SVC. You've got contrast that's passed through into the pulmonary veins and the aorta, but essentially no contrast in the pulmonary artery. So this would be a non-diagnostic scan. Motion and streak artefact and mistaken anatomy I kind of lump in together because they tend to cause false positive readings. So in this case here, I hope that's projecting for you, a patient with a left-sided lung cancer, there was an apparent filling defect on the right. When we have a look in a multiplanar image, so this is a coronal reformat, we can see that the slice didn't come right through the central lumen, it came on the vessel wall. And so then we have this problem of partial voluming, where in the 3 or 5 millimetre thickness voxel that's being displayed, you're getting some very low density structure, so some of the lung, you're getting low density vessel wall and only a little bit of the contrast. So it's presenting as much lower than it really is. So partial voluming also causes problems with motion, that's what motion artefact causes. So either in-plane motion artefact, typically from cardiac pulsation in the lingula, where the vessel's moving in plane, or through plane artefact related to respiratory motion at the lung bases. And it happens for the same reason. It's partial voluming through the vessel. It's important that we look at the lung windows to try and assess for that, because you won't pick it up on the mediastinal windows. In terms of mistaken anatomy, here's a case where you could easily think that this is an expansile filling defect in left lower lobe segmental branches. But as we have a look at the lung windows, we see that this patient has bronchiectasis and quite significant bronchial wall thickening down at the base. And you track and follow those tubular structures out, and we see that they're just mucus-filled airways adjacent to the normal enhancing pulmonary arteries. So this is just about careful review of the imaging. Talk about regional hypoperfusion due to hypoventilation, so a problem that you guys encounter in VQ scanning as well, but we see it in CTPA too. So this was a patient with emphysema who had a clinical deterioration, came for CTPA. We saw this unusual kind of lace-like filling defect in the right pulmonary artery, and as we followed it down in the right lower lobe, they're developing a fluid level, quite unusual, and then a complete lack of opacification towards the periphery, where we've got a nice normal vessel enhancing on the left-hand side. So we were quite confident that this was a flow phenomenon, but understandably the clinicians wanted confirmation. So we brought the patient back and we gave them slightly more contrast, we slowed down the injection rate, and we delayed the scan. And so in doing so, we get contrast in the aorta, so the aorta is opacified. We've still got contrast coming in the SVC, and now we've got complete filling in of that main pulmonary artery and the lower lobe branch. Why did it happen in this patient? Well, I mentioned he had emphysema, but he had quite significant bullous change down at the right base, and in fact had undergone endobronchial valve therapy, you can see there on the images, in an attempt to perform lung volume reduction. It hadn't been successful, so he had the double reason to be poorly ventilating that region. So all of these things we have to be thinking about, because if we don't optimise our scan protocol and also the way we're interpreting the images, we can end up with a non-diagnostic scan, which is kind of the worst case scenario, because you need to repeat the study with the commensurate sort of doubling of radiation dose and contrast dose to the patient. Or equally badly, in some senses, we can end up with a misdiagnosis, and usually they're false positive studies, and it can go on to lead to unnecessary treatment for those patients. We want to avoid those. I'm just going to take a sidestep to briefly mention 3 specific patient issues where VQ is preferred. VP, there you go, sorry. Pregnancy in the peripartum phase, someone's going to be talking about that later in this session, but in terms of radiation dose, we're thinking about the dose to the fetus and to the radiosensitised female breast. The dose to the fetus is probably comparable in the first and second trimester, but most of the PEs are happening in the third trimester when the dose with CTPA is significantly higher. The dose to the breast is significantly higher with CTPA all the way through pregnancy and in the postpartum phase, and it's that combination of reasons that's probably led our college and many others around the world to recommend VQ as primary imaging for most pregnant patients. If you are going to do CTPA, you need to predict that need for increased contrast. That's probably part of the reason why there's such a high non-diagnostic rate in pregnancy. And on the plus side, I guess for CTPA, you can breastfeed all the way through in the postpartum phase, whereas you'd usually suggest a lockout of about 13 hours after VQ. Patients with renal impairment can be a problem. We really don't worry until we're getting down to EGFRs around the 30 to 40 level. We can IV prehydrate and decrease contrast in these patients, but really, they're probably better off going for VQ. Similarly with contrast allergies. So if it's a fairly minor reaction, we can steroid pre-medicate these patients, but really if it's a significant allergy and VQ is feasible, then that should be the preferred test. So coming back to all our problems, so we've got all these problems, we need to think of fixes, and really the ones we've mentioned already are to do with protocol tweaks. So suboptimal opacification, we need to make sure we're giving the right dose to the right patient, and we try and get them to do that submaximal breath hold. Motion and streak artefact, we're doing faster scan times all the time. Several seconds now we can scan a patient's whole chest. In the olden days when we didn't have such fast scan times, you might scan them feet first to minimise the respiratory artefact, motion artefact. And we give a saline chaser at the end of the IV contrast injection to flush out the contrast as much as we can from the SVC and minimise the streak or beam hardening artefact that we get there. Mistaken anatomy, that really comes down to us as radiologists doing a really rigorous multi-planar review. And regional hypoperfusion due to hypoventilation is something we can't really predict, but we can tackle in a repeat study by delaying the scan, changing the delay and increasing the contrast dose. So sadly, that's not where the problems with CTPA finish. There are more problems that we've got to address. We talked about dose in pregnancy briefly, but we've got to worry about dose in all patients, both to the whole patient and also to the breast in female patients. And this has really been tackled over the last decade or so with decreasing KVP techniques. So previously, a standard sized patient would have a 120 KVP study. Now most scanners would recommend 100 KVP for these patients. Just that drop of 20 KVP decreases the radiation dose by 30%. But like anything, when we get something good, we take a hit somewhere else. So we get an increase in noise of about 20%. And this is where iterative reconstruction has been so important. So the iterative reconstruction sort of balances off against that noise. It smooths out the image. And as a side benefit, we also get increased contrast to noise ratio. I've already talked about the automated tube current modulation, but another lovely new technology has been modulation of the anterior current. So most scanners would now have the ability to decrease the dose that's delivered to the anterior arc of the chest and commensurately increase it posteriorly. So overall, your image quality in the lung is not changed, but you've decreased the absorbed dose via the primary beam to the breast by about 30 to 40%. So we raise the question of whether or not CTPA is just too accessible. Is it being overused because we make it too easy to get it? Well, you're probably right, we do, and it's something that we all need to be careful of when we're the gatekeepers of radiation in our society, and really radiologists should be expecting that an appropriate pre-test risk assessment has been performed and that any ancillary tests like D-dimer and ultrasound have been used appropriately as well. Something that people don't often think about as well is that CTPA is not optimised for lung parenchymal imaging. We get some information about differential diagnoses, but if what you're worried about is the lung parenchyma, you should do a dedicated test. So it's for a couple of reasons that I've already mentioned. We sometimes exclude the extreme lung apices and bases. You might miss early fibrotic changes. We're not taking these scans on maximal inspiration, so the secondary pulmonary lobule is not inflated as much as it should be. But also, with the phase of contrast enhancement, you can sometimes get the false impression of centrilobular ground glass nodules, and that's due to just normal enhancement of the lung parenchyma around the vessel. So this is about educating and making sure that we order the right test for the right clinical indication. So then to the problem of overdiagnosis and overtreatment, and I think this is such a big problem, it's getting its own slide. So people talk about the paradox of high quality CT. I like to, tongue-in-cheek say, is CTPA just too good? So we're picking up findings that we never used to see because the image quality is so good now. We're picking up little tiny single subsegmental PEs out in third and fourth order branches now. What do they mean for the patient in reality? There's a lot of evidence out there about this now. I really like this old population-based study by Burge from 2008. They looked at 25 million inpatients in New York State between 1994 and 2004, so sort of during the upswing of acceptance of CTPA. And over that time, the PE diagnosis doubled. My thing's not working, that's right. I'm sure you can see on the graph that the PE diagnosis doubled over that period of time with absolutely no impact on mortality, which is the lower line there. So a clear pattern of overdiagnosis where we're finding more disease but it's not making any difference to the patient. And this is almost certainly due to diagnosis of these little single subsegmental PEs. We also find incidental abnormalities on these scans, and we can create these vomits or victims of medical imaging technology where, no one would argue that finding a 1 centimetre lung cancer incidentally is a good thing for the patient because it's potentially curable disease. But if we find a 6 millimetre pulmonary nodule here and a 1 centimetre thyroid nodule and a too small to characterise liver lesion and a little adrenal thing, it causes problems. So not only are those patients going to worry about the findings, they've got to go through there's extra cost and inconvenience associated with additional imaging. We also can run into problems of diagnosing clinically insignificant disease there as well, and potentially even treating insignificant disease. And in the worst case scenario, I guess, having complications related to unnecessary investigations or treatment. So this is where we need to depend on some clinical decision-making tools. We've got really good ones out there for incidental findings, such as the Fleischner guidelines for pulmonary nodules. There's similar guidelines for thyroid nodules and adrenal lesions. But I don't think we've got a good overall view on what we should be doing in managing these small subsegmental PEs. Hello. I'm not advancing. There we go. Just very briefly, future directions, further lowering dose, always looking to decrease the dose in all patients all the time. And we're doing that with lower KVP techniques and increasing iterative reconstruction. So there have been some recent publications reporting sub-millisieverts CTPA, which is pretty amazing. Individualising contrast doses, so we've talked about weight-based adjustments, but also something to think about is as we decrease the KVP, we get a sneaky side benefit because as we decrease the KVP, we approach the K edge of iodine, and the Hounsfield unit that you achieve for the same contrast dose increases. So by going from 120 to 100 KVP, for example, you'll get a 100 Hounsfield unit bump in the pulmonary arteries for no additional contrast. So you can actually drop contrast doses in these patients as we move to lower KV techniques. Dual energy CT perfusion imaging is beautiful and it's coming. It improves our confidence in PE diagnosis, and it may even end up being a one-stop shop for chronic thromboembolic pulmonary hypertension. So hopefully you'll feel a little more enthused about CTPA and not so, well, not that you're all negative about it. I'm sure you'll embrace CT when it's appropriate. You can see that it's a quick and accurate test. We see some information about the differentials for PE, but also the downstream effects of PE. We've talked about what makes for good images and what makes for bad images, and the problems that we all need to address ongoing with dose overuse and overdiagnosis. So thanks very much, everyone.
Di, thank you. That was a fantastic 20-minute overview. Much appreciated. I suspect if I open it up to questions, we'll be going for about half an hour. So perhaps if you don't mind, if you could stay at the end, and if anyone has any burning questions, come up. And hang on, before you escape, the organisers have gone to great trouble to get this for you, to just acknowledge your time here. So thanks for having the afternoon off from work to come down to us.
Thank you very much.
Thanks very much. Good. All right, so radiation was certainly touched on, and I think for all of us in nuclear medicine it's highly relevant. So we're fortunate to have Professor Frederick Fay with us from my old stomping ground of Boston Children's Hospital in Harvard. So Fred's going to give us an overview of the relevant radiation factors for VQ and CTPA.
Thank you very much. I really much appreciate being here. I also wanted to thank some of the people over the years who've helped me understand the CT side of things a little bit better, as well as my colleagues in nuclear medicine, Jim Edelstein and Ted Trevis. Unfortunately, I have no disclosures that pay me any money with any of this work. So, and I put up the MERD equation here. Let's see if. And I just put this up quickly because I'm going to talk about the dosimetry from both the VQ scan as well as from the CTPA. And this can sort of be broken down into two parts. This part is sort of the physics side of it. It includes the energy per disintegration here, as well as the absorbed fraction. That is, what fraction of the radiation that was emitted from the source organ is absorbed in the target organ. Maybe, for example, in this example, the breast, as well as the mass of the target organ. So this is stuff that we can either look up in a physics book, or we can model for some particular model, a young woman, for example, from some standard phantom. This is the one that's a little bit tricky for us, which is the time-integrated activity, and that is how much of the administered activity went to the source organ and how long did it stay there. So it has in it physiology, which we don't know for any individual patient, and could be quite variable. So when I show you some of these dosimetric estimates on the nuclear medicine side, it could be off by 50 or even 100% because we don't know that for an individual patient, and it probably has some variability we have to take into consideration. And then we could calculate, we will calculate or could calculate dose to a number of different organs, and I could give you a list of 20 organs that we calculated dose. But people sometimes like to see one number, and so we will be looking at one number, which is the effective dose, which is basically taking the organ doses, all the organ doses that we calculate, weighting them by some factor that has something to do with the radiosensitivity, and then adding those together and coming up with one number that presumably tells us something as if you had radiated the patient from head to toe uniformly, what would be the risk of that? And this gives us something that perhaps is similar to that. But remember, these weights are based on population averages, not specifically young women or not specifically children, in my case at Boston Children's Hospital, and not particularly for any particular patient, but for perhaps a population kind of look at risk. And the weights have changed over the years. About 10 years ago, ICRP 103 changed these weights. And pertinent to this discussion is that the weight for the breast tissue went up by a bit. And so if we're talking about irradiation of the chest, we're going to find that the effective dose is going to go up because the breast value has gone up. These still add up to 1, but you notice that the gonadal weight went down and the breast went up about 10 years ago, and that will change, and we'll talk a little bit about that. And I should have said up front that much of what I'm going to discuss today is in the context of the fact that pregnant women and postpartum women are at a significantly higher risk of PE. This audience knows that a whole lot better than I do, and so that is where I'm going to focus the dosimetric discussion today. Okay, so I'm going to look at perfusion imaging, VQ imaging. For this audience, I probably should have put tetanus gas in here. Obviously, we don't use that in the U.S., so unfortunately, I don't have that, and I apologize for that. And these numbers that I got are basically based on the Society of Nuclear Medicine Molecular Imaging guidelines, and that's where I got these numbers for the administered activities for these that I'm basing the dosimetry I'm going to present. So based on those numbers, administered activities here, I estimated in this case and in other cases that I'll look at both an estimate of the breast dose, an estimate of the effective dose, and an estimate of the fetal dose. And I took three months where perhaps you would be particularly concerned or earlier than that with respect to any kind of teratogenic effects to the fetus. And so you can see the calculations here for MAA, for low dose MAA on the low dose of what I showed you on the previous slide, and for technetium-9 aerosol and for xenon. And you get a sense of these numbers, and I'll come back to these later. The breast dose and the effective dose are based on ICRP 128 values, and the fetal dose are based on S values that were provided to me by Mike Stabin. So I'm going to change gears now to CT dosimetry and give a little bit of what we measure to do CT for dosimetry that perhaps people aren't familiar with, and then make some estimates. The CT dosimetry goes basically as MAS, tube current times time, linearly. With respect to tube voltage, it goes basically as KVP squared, as Diane mentioned. Reducing the KVP is a very effective way of reducing dose, and as she also pointed out, perhaps an effective way of improving image quality in CTPA. Patient size, pitch, basically how fast does the table go. So if you can image the same volume in half the time, you will give the patient less dose. So the higher the pitch, the lower the dose. And often you'll see those combined with MAS and referred to as the effective MAS, as we'll see. Region of the patient imaged we'll talk about. The use of tube current modulation, again, that Diane mentioned. About maybe 5 or 10 years ago, there was a bit of work looking at the use of bismuth breast shields. They sort of have gone out of favor, but I still had them on this slide. So one of the things you'll see that when we talk about is CTDI, and what is that? And it's dose measured in a phantom, so not in a patient, but in a phantom. Typically in the 32 centimeter phantom, and you can see it has hole in the middle and some holes on the periphery. And so you put the ion chamber in it, and you irradiate it with the CT scanner, and you measure the dose. And we will make some estimates with respect to this in units of milligray. So if you measure CTDI 100, which is you measure, but then you take this, this average of the value in the center times 1/3 plus the value at the edges times 2/3, you get CTDI vol. And if you divide that by the pitch, you get CTW, excuse me. You divide that by the pitch, you get CTDI vol. And that's what you see on your scanner when you set up a protocol. Now, this is not the dose to your patient. In fact, it calculates this dose before you even put your patient in there. So whether your patient's thin or heavy or anything, this is determined based on the parameters that you entered in. You entered the KVP, you entered the MAS, you entered what the collimation was going to be, you entered what the pitch is going to be, and based on that, it calculated what the CTDI vol would be. Now, CTDI vol is measured with one slice, and it's a dose. It's a dose quantity, so that if you remember, dose is radiation dose is energy imparted per unit mass, and so if you did 10 slices, in the CTDI for one slice was 20 milligray. For 10 slices, it would still be 20 milligray because you've multiplied how much energy you deposited by a factor of 10, but you've multiplied the mass that you've irradiated by a factor of 10 as well. And so it's the same. Now, you might think that biological risk does have something to do with how much of the patient you irradiated, and so maybe CTDI vol doesn't give you the whole answer there. And so people have gone to the dose length product, or DLP, which is basically CTDI vol multiplied by the scan length. So now you take these 10 1-centimeter slices, you multiply this 20 milligray by 10, and you get that that's a DLP of 20 milligray centimeters. And if if the scan was twice as long, you would get a DLP of 40 milligray centimeters, and perhaps the DLP better represents the biological risk. And so people have used that to estimate effective dose. And this table is from this article from Cynthia McCullough from about 10 years ago, where she came up with what are called K factors, which basically allow you to make some estimate of the effective dose by multiplying the DLP by this factor. So the one that might be most interesting to us is over here for adults in chest, and if you multiply by 0.014, perhaps you get some estimate of the effective dose. I did note up here that this is based on the ICRP 60 weights, and I told you that they changed to ICRP 103 with a higher breast weight. And so if you do this on do the calculation using the ICRP 60 weights, 400 milligray from the previous slide times 0.014, you would estimate maybe the effective dose is 5.6 millisieverts. However, if you look at this article by Christner, they would say that perhaps the K factor should be actually 0.021 if you use the ICRP 103 weights, and if you do that, you get a number of 8.4 millisieverts. And so and this one is the more appropriate one using the ICRP 103 weights. Now, there's other ways besides just doing the K factors. One thing that might be a little bit more effective is, or accurate, might be to use some software that allows you to irradiate a phantom and make some estimates. So the one I used here was CT Expo, and you might have heard of Impact, and I'll show you some data from Impact. But basically, this is a spreadsheet. It has some data incorporated into it from Monte Carlo calculations, and I'll show you the results of that. And you can buy this software. Again, it's basically an Excel spreadsheet that you put in the numbers, and it tells you some of the answers. And this is the data I put in. I put in for Siemens Sensation 64. I considered 3 KVPs for the reasons that Diane mentioned, that a lot of people have gone to 100, and even some people have gone to 80 KVP. But I just kept the MAS set, I kept the pitch set, and I considered the field of view to go from the diaphragm to just above the lung apices, which in this software was about 27 centimeters. And when I did that, I got these estimates of CTDI vol, DLP, And then the maternal effective dose, the breast dose, and the uterus dose. I didn't actually have an estimate in this for fetal dose, so it could be slightly different for that. And you can see that the breast dose is, depending, is about like 12 and 22. So you see almost a factor of 2 reduction in breast dose if you go from 120 kVp down to 100 kVp. It doesn't scale linearly, it scales as kVp squared. And the effective dose as well goes from 8.8 down to 5.1. And this 8.8 is similar to the estimate I got on the previous slide using the K factor. So maybe we're in the, I think that was 8.6. So we're in the same ballpark there. And looking at some other estimates from other recently published articles, this is using anthropomorphic phantoms and some estimate, low KVP and MES of 120, and this estimated that the breast dose was 5.6. The maternal effective dose was 2.1, and the fetal dose was 0.12. Again, if you look at this, it's a little bit lower than this, but they used about half the MAS that I used. So probably again in the same ballpark. And then this is a survey of practice in the UK, looking at a number of 256 CPAs and 764 VQ scans, and they estimated in this survey that the breast dose ranged from 2 to 14. This is sort of in the middle there. The fetal dose is a bit lower than this. And then they compare the fetal dose to the VQ scans. And the fetal dose for the CTPA is significantly less in this case than the VQ scan, because the radiopharmaceuticals sort of go everywhere and irradiate the fetus as well, whereas the fetus in the CTPA is only being irradiated by the scatter radiation from the field down to the fetus. Isidoro used impact, which is similar to CT Expo. Again, their parameters are a little bit different here. Their breast, and they estimated the breast dose of 22 milligray compared to VQ scan. Fetal dose, these are quite similar. And if I took my estimates with CT Expo and scaled it with their MAS and scaled it with their different pitch, I got almost exactly the same value within just a couple percent. So these numbers seem to be reasonably consistent. And then I tried to do a comparison here of low-dose perfusion. I'm just using low-dose perfusion that you saw on the previous nuclear medicine slide, a VQ scan here, and then CTPA here. And I put in a range based on all that data that I just showed you. And you, in general, can see that the breast dose, as Diane mentioned, is considerably higher, maybe as much as a factor of 10, up to maybe a factor of higher than that, higher in CTPA. And for the approaches that are basically being used now, but I'll get back to what Diane mentioned about maybe some opportunities to reduce that. And then the maternal dose is a little bit higher, maybe a factor of 2 or 3 or 4 higher in CTPA than it is for let's say the low dose perfusion scan. And the fetal dose is higher in the VQ scan than it is in the CTPA, but low on all cases. This is reasonably low and significantly lower than the 100 millisieverts that the ICRP report on the NCRP report from the U.S. would say that would be your concern with respect to fetal dose. Now, a number of organizations, because of these data, have looked at this over the last few years. This is from about 5 years ago, the Choosing Wisely campaign from the American Board of Internal Medicine Foundation asked organizations to look at things providers and patients should question. And I guess about 5 years ago, the SNMMI offered this to the Choosing Wisely campaign. Avoid using computed tomography angiogram to diagnose pulmonary embolism in young women with a normal chest X-ray. Consider doing a radionuclide VQ scan. The American Thoracic Society put out this recommendation 5 in pregnant women with a suspected PE and a normal chest X-ray. We recommend lung scintigraphy. Then they down here say in patients with a non-diagnostic VQ scan in which the decision is made to further investigate, we recommend CTPA. And I was involved with this, as Marika was also involved in working on the appropriate use criteria for the Society of Nuclear Medicine Molecular Imaging, and I was the dose guy and sat on these. And we went through and came up with 21 scenarios. I was pleased, and I think the group was pleased, that this appropriate use criteria were almost immediately adopted by the American College of Emergency Physicians. The American Society of Hematology affirmed that this was of value, whatever that means. If you look at the 21 scenarios, you look at scenario 15, it said this is in cases where PE is likely in pregnant women with a normal or mildly abnormal chest x-ray, then they considered that a low-dose perfusion scan was very appropriate. This 9 is very high on our scale of appropriateness. And if you're interested in that, this is the link to it. And I'm happy to send anyone the slides. Just email me, and I'm happy to send anyone the slides. So in conclusion, if you look at CTPA compared to VQ scans, breast dose is considerably higher, maybe 5 to 10 times or even more than that higher, maybe up to several tens of higher than VQ scans. The maternal effective dose is slightly higher, maybe a factor of 2 or 4, and the fetal dose is lower, but they're both quite low. But remember that these estimates have a bit of uncertainty, don't apply to any particular patient, but to perhaps a class of patients, and allow us to have this conversation. But again, as Diane pointed out, there's a number of different advancements and protocol modifications that are going on to try to lower the dose from CTPA, including, as she mentioned, lower KVP and contrast dosage, the use of tube current modulation. In some instances, I've seen some papers looking at dual X-ray CT machines may be a way to do this, and iterative reconstruction making this all possible. So we may see over what I presented is probably a reflection of the practice now, but 5 years from now it may be quite different because of these advances in instrumentation. So with that, thank you very much, and I'm happy to answer questions when appropriate.
So thanks, Fred, for an excellent overview. And again, I don't want Henry to miss his plane, so we might keep you at the end for questions if people have them. Marika.
Yeah, and now I have the honor to present Dr. Jeff Shembri, nuclear medicine specialist from Royal North Shore Hospital in Sydney, working for a very long time in this field.
Thank you. So Fred, I just love all that geeky stuff. That was fantastic. So I'm going to try and bring it all together in 15 minutes or less. So fasten your seatbelts, hold onto your hats. Here we go. So this is the typical scenario I think that we face. It's a young woman. She's pregnant. She's got symptomatic chest pain. She doesn't smoke. So she's not on the pill, I hope. If she is, she needs a refund. And her D-dimer is a bit up. Has she got PE? So what are we going to do? It's a real problem. Acute pulmonary embolism is the leading cause of maternal mortality, and women who are pregnant are at an increased risk of PE for all the reasons that I'm sure you guys all know. So what's the appropriate diagnostic pathway? It remains controversial, particularly amongst many of our respiratory physician friends. There are a lot of guidelines out there. They often reflect their local strengths and biases, and that's normal. But what have we got? The options, we've got a clinical, we've got Doppler, we've got VQ, we've got CT. So let's have a look at the clinical. The incidence of PE in pregnant women, so there was a recent meta-analysis where they looked at over 25,000 patients in total. And it was interesting to note that in the non-pregnant population, the diagnosis of PE was made in only 12%. So even in patients who aren't complicated by pregnancy, your clinicians are doing a 1 in 10 job. Once they're pregnant, the actual positive rate dropped to 4%. That's not because PE is less common in pregnancy, quite the opposite. It's because the threshold of sending them for a test is so much lower in pregnant women. They get a lot of symptoms. No one wants to miss PE in a young woman who's pregnant. What about the D-dimer? Looked very quickly. They rise throughout pregnancy. Our client did a study to show that no woman had a normal D-dimer in the 3rd trimester. There's a case report showing the reverse, that your D-dimer can be negative with PE. And I think the DIPEP study hopefully is the nail in the coffin for this. They looked at 310 patients. They found that none of the biomarkers of clot were of any use in pregnancy, and they made the specific comment that in particular D-dimer should not be recommended for use in the diagnostic workup of PE in pregnancy. So your clinician should not do the D-dimer, and if they do and they tell you it's up, you should say, so what? It means nothing. DVT ultrasound, look, it's cheap, it's easy, there's no radiation. Even in women who are pregnant with leg symptoms, the positivity rate is still below 10%. So it's not a high yield test, but hey, it's cheap and easy. The North American guidelines say you should restrict its use to patients with symptoms. You've got to be careful how you do it. Pregnant women are much more prone to have high iliofemoral DVTs, allegedly more pelvic thrombus, so I don't know if any papers actually prove that. And then the other problem is the below knee thrombus. If you scan asymptomatic pregnant women below the knee, about 1% will have a small clot. So if you do one in one who's got chest pain and you find a little clot, what does that mean? So I think above knee clot certainly is different. CTPA, I think we've had some good stuff to cover. One of the things about CTPA that my clinicians keep banging me on the head with is it gives us alternate diagnoses. And that might be true, but most of these diagnoses are things that I don't know you necessarily need to do CT for to make that diagnosis. These women who are short of breath with pregnancy, they often have a bit of atelectasis. Some of them will have pneumonia, hopefully with a fever or cough, and some of them will have a small pleural effusion. If you look at a few studies, and there are not many on this, chest X-ray catches nearly all of these. However, the CT did add some of these diagnoses in somewhere between 2.5% to 13% of patients. So there is an improved yield on the CT of finding these other findings. I guess what's never been really studied is, does that matter? Is there a management impact associated with that? I think a really important thing about CTPA, because I think CTPA is a great test for PE, is that in pregnancy there is a much higher indeterminate rate. And I was surprised by these numbers. I spoke to our radiologists. They said, no, this is true. It's really hard to do a good quality CTPA in pregnancy for the reasons that we've already covered. So up to a third of CTPAs in pregnancy will not reach that high diagnostic quality. VQ is a bit less available. It does give you some idea of match changes, and we would argue it has lower radiation. And look, it has a pretty good accuracy, and the most important thing is that our indeterminate rate is not affected by the fact the woman's pregnant. So this study from Montefiore and our good friend Lenny, he looked at women who had been referred either at pregnancy or in the early perinatal period. They did 225 VQ and nearly 100 CTPAs. Now they do an ultra low dose study. They do 25 megabecquerel planar. And their CT was initially 16 and 64. Again, they found that very low incidence of positive PE. The indeterminate rate for both was about 9%. Now that's a bit high for the VQ, but probably because it's only giving 25 megabecquerels, and that's actually surprisingly low for the CT. They both had very good negative predictive values. Incidentally, they noted that asthma wasn't a problem for VQ in pregnancy, and he noted the D-dimer was positive in all of them. But they did make this comment. Unfortunately, they don't give the number, but they did say, in most cases, CTPA found nothing significant over the chest X-ray. This study by Cahill, which is an O&G journal, they also reinforce this, that in the setting of a normal chest X-ray, the CTPA is much more likely to be non-diagnostic and not of any additional benefit. Some more recent data from Grunning, they looked at 168 patients and 89 controls. Some of them had SPECT, some had CTPA, some had Doppler. The Doppler reinforced what we've already said. They had a very low yield of positives. SPECT, there was only one intermediate result. CTPA, 35% were considered of insufficient quality, and the diagnosis rates were the same. So let's just very briefly touch on radiation. I know that Fred's already done a lot of this for me, which is great. Maternal and fetal images need to be considered and balanced. I think this is what I'd like to stress, that you need to have some balance in your assessment. And if you're going to do that, you're going to try and estimate exposure and estimate risk. Obviously, the target's slightly different between the two, a bit more breast with CTPA, a bit more lung with the VQ. And this is Venus Rising, who is a woman, I'm told. And if we irradiate her breast, we would hate to cause something bad to happen to her. So let's see what we can actually do. So I think that while there's a lot of phantom studies, and the phantom studies are great, real world is often different. These are the last 3 pregnant CTPA studies done in our hospital, and you can see that the breast dose ranged from 17 to 27 millisieverts, and the effective dose from 7.4 to 12. So despite best of intentions, this is 100 kVp, and I'm trying to do things well. It's not that easy in pregnant women. They sometimes don't cooperate with getting stuff done. Business shield, I'm just going to mention to dismiss. Yes, they can reduce the dose. No, I don't think a lot of people use them. If you reduce the KVP and add shields, you can certainly reduce your dose by up to 40-50%, but that comes at the cost of getting a lot more anterior defects on the CT. I'll skip this because it's already been covered. Just to show you iterative reconstruction, this is filtered back protection, this is initial iterative techniques, this is current techniques. And I think you can see that even at 25% of the dose, the iterative maintains very nice diagnostic quality. And we've also covered that. So what about the radiation risk? Is this a real risk, and do we even need to care? So this study by Newman looked at 691 patients who had CT. This was using contemporary techniques from 2011. They estimated the dose using CT ESPO, and they found that the breast dose varied a bit as you got older, presumably due to changes in breast size, and it was around 12 millisieverts, 14 if you're a bit older, and the lung dose was also in that same range. They then looked at BS7, which is one of the radiation pamphlets out there that you can use to calculate dose. They looked at the lifetime attributable risk to this exposure, and they found that they estimated about 50 excess cancers for every 100,000 CTPAs in 20-year-old women, which would lead to about 12 deaths. So that's about a 1 in 2,000 risk. So let's put that in real-world terms. So 1 in 2,000 risk, 1 in 3 of us in this room are going to die from cancer. 1 in 83 of us are going to be killed in a car accident. 1 in 700 will die before the age of 40 from any cause. If you cross the street, you've got a 1 in 1,000 chance of being killed. A lifetime risk of drowning is just over that. So the breast cancer risk is coming in here, which is the same risk as an accountant dropping dead at work from any cause. So if you sort of try and put these together, you know, what are the range of exposures we're getting? Chest X-ray is very tiny. I put Technigas in for you, Fred. It's also very tiny, and we have these other doses that have come out. I do make the point, if you do a low-dose CT, as we routinely do on most of our specs, that will add a lot to the pregnancy total. So we actually don't do it in our pregnant patients. The breast dose, again, is quite small from the nuclear medicine study, and as we've discussed, significant from the CTPA, but even not insignificant from the low-dose CT if you do those. So yep, consider whether you really need that in a pregnant patient. So if you look at this study again from the Grunig, they looked at the VQ study using Technigas and MAA, and this is that reduced dose study I think most of us have used. It's a half-dose study we usually acquire for an extra 50 to 100% of time. And this was a 64-slice CT. And the numbers are very similar to what we've all seen. Okay, the dose from the VQ is quite low. It's from CT in the breast, it's a bit higher. And the fetal dose is sort of barely nothing, and then half of barely nothing. If you look at the BS7 for breast cancer, they quote figures of around 4.3 per 100,000 as we discussed. I just make this point in case any of you like to read this literature. Land, and this figure was thrown around a real lot initially. A much higher relative risk was quoted. This took me ages to find the original paper. This was only in a study of very early onset breast cancer patients, presumably patients who are genetically predisposed. So I don't think that risk is one you should be using. I think this number, which is similar to these, is a much more realistic number. What about the radiation risk in pregnancy? Well, unsurprisingly, it's been really hard to get volunteers for this study. So this is about the only study we have. These are women who had Hodgkin's disease, and they could be convinced to have radiotherapy. Their risk of breast cancer was 7 times higher if they were pregnant during the therapy than those who weren't. So I think that's good evidence that we would accept that breast tissue is probably quite proliferative in pregnancy and at higher risk. So is there any real work, long-term studies on this group? And the short answer is no. So Burton started, they looked at nearly 6,000 patients. They compared that to 1.3 million women who did not have CTPA, and they tried to get an idea of the risk. The problem with this paper at the moment is the follow-up period is too short. So breast cancer risk takes up to 50 years to run through its whole course, and so a study that's only showing you the last 6 years won't show much. And unsurprisingly, they found that there was no increased risk in that time period. The lung cancer risk, it's about the same, so you don't really need to worry from both studies. There's no reason to choose one over the other. Summary slide, just to bring all those numbers together. Chest X-ray gives hardly anything to anyone. CTPA doses around 10 millisieverts up. Fetal doses, look, lots of variation in what's reported, but I do think the important thing here is that they're tiny and tiny. And I just make the point here that Technigas gives almost no dose to the baby in pregnancy, and that's why, unlike a lot of people, I still advocate doing a Technigas scan in the pregnant women, because I think the dose to the baby is tiny, and why wouldn't you? Estimates of exposure to the baby then. Look, there is evidence, not of fetal malformation. We're way below fetal malformation doses here. But what about the increased risk of childhood cancer? So that's the one theoretical thing I think we have to bear in mind. Estimation is difficult. The estimate out there at the moment is about 8% excess risk per grey of exposure. So if we say that our study's giving the baby around half a millisievert, and that's being generous, then the risk is about 1 in 2,500, so just behind our accountant. You've got to remember the background exposure, depending where you live, is somewhere between 2 and 3 millisieverts over pregnancy anyway, so we're giving a fraction of what the baby's going to get just by existing. The background risk of a fetal abnormality is 1 in 30, and the background risk of childhood cancer is around 1 in 300. So your additional risk here is 0.012%. Is this a mathematically valid number? I don't know. You would have to do a study with millions of participants to prove this was a genuine factor. So where does that leave us here? This is pregnant Barbie. I know you all wondered that Ken just had a mound, but apparently it was more effective than we ever thought. So here's our 20-year-old woman. She's pregnant. Her baseline risk of breast cancer, depending upon her nationality, is about 1 in 8. We're going to give her an additional risk from 10 millisieverts of about 4.3. Because she's pregnant, we're going to multiply that by 7. So look, the risk, additional breast cancer risk, is about 1 in 300. So it's not nothing. It's probably a reasonable amount that you would try and avoid if you've got another test that can perform as well, if not slightly better, in this scenario anyway. If it was 20 millisieverts, then her risk, of course, would double. The risk for a VQ is tiny. So what do we know? CTPA is a reduced accuracy in pregnancy. The CTPA yield of alternative findings is probably around 10%, but we don't know what the management impact of that is, if any. Breast dose is definitely getting down, but it's still a lot more than the VQ. Lung dose is similar. Fetal dose is likely similar, and anyway, I think it's irrelevant for both procedures. Don't do D-dimer. Remember, your incidence is low, so you want to do the most safe test you can, because so few of them actually have the disease. And there's no short-term evidence yet for cancer induction, but I think the research would suggest that long-term induction is a real and a genuine risk. So what do I think you should do? This is the West Australian Diagnostic Pathway. This was done in 2016, so that was before the DIPEP study. So now that the DIPEP study out, I would cross this one out, so ignore the negative D-dimer arm. I would do a chest X-ray, and I was talking to my physicians this week, and they said to me, we don't like to do chest X-rays because we don't want to irradiate the woman's breasts. And I went, okay, but you'll do the CTPA. And they went, yeah. So the capacity for self-delusion is a human trait. So if you do the chest X-ray, you might have an alternate diagnosis established. We had a lady a couple of years back, she had a spontaneous pneumothorax, and a chest X-ray was all she needed to make the diagnosis. If after that you haven't sorted it out and you still think PE is suspected, if it's easy to do the DVT ultrasound, low yield but low risk. And if it's positive, hey, you can then treat on a presumptive basis. If the chest X-ray is normal, and I would argue if it's near normal, I think you do the VQ. If there's gross abnormality or something clearly going on in that chest X-ray, then the CTPA is the best test. Am I going for time, Dr. Ray?
You're over time.
Then I better shut up. So that's all then, folks. If anyone would like a copy, my email is jeffshembry@gmail.com. I'm happy to circulate this to anyone who would like it. Thank you.
Thank you, Jeff. Now I will present known physicist, Professor Dave Bailey from the Safe Hospital. Please.
Henry, we're going to get you on that plane, don't worry. I'm talking about the non-PE applications, and Henry and I moderated the first session 2 days ago, and he said to me, "Are you still doing this lung VQ stuff?" And from a research point of view, the answer is actually yes. We always seem to have at least one research protocol involving VQ on the go. It's changed a bit with the introduction of CT, I think, because CT gives us a lot more information to complement what we get from the VQ studies. From the physics point of view, of course, we get the ability to attenuation correct, and that leads us into a whole new area of quantification. And, but of course, importantly, the morphological correlation is one of the greatest advantages of having the CT scan. We've used it in many ways. We've used it to look at lobar analysis, so if the functional contribution of each lobe to the ventilation and the perfusion. Obviously, we can use the CT scan to define the fissures and segment the lung, and then use those as regions of interest to ascribe function by lobe. So here's an example from the CT scan. That's what the segmented lungs look like based on the anatomy. There's some recent publications, but I'll skip through in the interest of time. As a byproduct of one of the studies we did recently, we scanned some normal people and looked at their lobar function. We did it as part of the protocol. They were injected upright and ventilated upright in one visit, and another visit they were in the more conventional supine position for the administration of the Technigas and the MAA. And we also looked at the CT volume, albeit with the caveat that it's a free breathing CT, because it was at the time we were using a single slice CT because it was a spec CT combined scanner that we built ourselves, and so we used a pre-loved CT scanner that had no value to the private practice anymore. So we looked at quantitative ventilation and perfusion and correlated with CT volume, and you can read these things like a bit of a chest X-ray. So there's the left upper lobe, left lower lobe, right middle lobe, upper and lower there. And so we could actually get the actual contribution in normal people averaged over, I think it was about 12 subjects, or 11 subjects it says there. So between upright and ventilation, and compare that to CT. And I'm always amazed in the lung cancer MDT meetings when the surgeons go into a great debate about whether they'll keep the right middle lobe or not. And I just think, you know, what's the point? Get it out. It's not contributing very much at all. Likewise, when you do supine, things change a bit, of course, and because of the gravitational changes and the dependence of blood flow and the subsequent ventilation on that. And so we've now we've mapped out for the normal ranges of lungs. And I can't think of any other way that you could really do this without perturbing the lung in some way. If you blocked off an airway or something, or you blocked off a blood vessel in some sort of research paradigm, you'd shift the blood and you'd change it. At least with this technique, I think we've been able to investigate what the actual contribution is to the normal lung physiology. So some of the applications that we've used this in the sort of research non-PE applications, we did a study which we call Pelicans, where we looked at lung function prior to surgery and correlated that with physiological parameters from the respiratory labs, such as DLCO and 6-minute walk tests. And here's a typical looking study. So here's a patient with lung cancer going to have their right upper lobe removed. And it was contributing 23% to ventilation and 24% to the perfusion. So when you're discussing these patients at the MDT, most of these people have got compromised lung function already, usually below 50%. So these studies come into their own and telling you actually how much you're going to lose. Sometimes you do the scan and they're not going to lose anything because it's not contributing anything anyway, especially if it's impinging on the bronchus. That's what our results look like when they come out. We look at the total volumes, we look at the CT contribution, the anatomical contribution, and compare that with functional information. And this was what we saw in our early part of our Pelicans test, that the change in the DLCO between pre-surgery and after surgery was reasonably well predicted by what we saw in the change in the functional contribution from the lung VQ scan. Another example from Pelicans. Here's an example where we had very little perfusion at all to the left lung, and so operating on that wasn't going to actually have much of an impact. Some cardiopulmonary physiology. We had cardiologists come to us and want to look at if we could develop a test for early diagnosis of pulmonary arterial hypertension before it became chronic and well established. And so we got a number of patients with an early diagnosis of pulmonary hypertension, and looked at, they had a catheter study as well as VQ twice. And this again was along the lines of that protocol I showed you earlier, where we did them both upright and in the supine position. And we were looking at the change in between the two, with the hypothesis being that the early changes to the microvasculature in the lung in the patient with pulmonary arterial hypertension would mean that there'd be little change when you change the position in which you administer the radionuclide, because they've lost the ability, the tone of the vessels has gone now, and they wouldn't be able to change that. So this is what the study looks like, again combined with a CT scan, of course, which helps enormously. So here's a patient, the plot from the base up to the apex of the lung. In the supine position, you can see that there's reasonably good perfusion, and it's evenly distributed across that axis. And then when we switch the patient to being administered upright, then you get a change. You get less at the apex, more at the base due to the gravitational changes. And that's the reason that we give the patient the injection in the supine position. Although I remember going back a long way that it used to be recommended that you could give the patient half the injection upright and half supine. But this is what the change is in the normal person. And that's what a subtraction of the two looks like. And so in the patient with this pulmonary hypertension at the bottom, what you can see is there's no change. So indeed the hypothesis was proven to be correct, that they don't change with any gravity-dependent way. So we published the article on this, how the pulmonary hypertension leads to loss of gravity-dependent redistribution. We also looked at, we've done a fair bit looking at VQ matching, and the classic technique, which is published by the Swedes a long time ago, is a gas-based technique with mass spectrometry, looking at multiple infusions of different inert gases, where you then sample the arterial circulation, and you're trying to look at the way the ventilation and perfusion match and against the expired air, and you get these sorts of curves with a ratio around 1, where hopefully the ventilation and the perfusion are well matched, and that's the optimum for the operational point for the lung. This is known as a midget study, a multiple inert gas elimination technique. It's invasive. It's still done. I know a couple of labs in Sydney still do it, but it's in a research protocol rather than in any clinical use. The Swedes showed that you could do this with ventilation and perfusion imaging, and they did something very clever. They did simultaneous ventilation and perfusion using 2 different radionuclides. But you could see that they produced curves here of the matching of ventilation to perfusion that look very similar to what I just showed you in the inert gas study. This is some of our own data showing the same sort of thing, ventilation and perfusion matching. In the normal patient, what you get is this sort of a curve. But in someone who's got, say, PE, where you've got ventilated lung but decreased perfusion, you would get an increased VQ ratio. It would exceed 1, and you start to get disruption here. What the imaging can give you, though, is regional information, whereas the gas technique only gives you global. So this is, I think, the value of the SPECT technique, of doing a regional sort of midget study, where we can look now using our segmented lungs and look at the different lobes and look at what the matching is like in each lobe, and so drill down to a further level of granularity. So we've looked at a few things here. Here you can see a patient with PE and the disruption that is there in the right lower lobe, as opposed to the other lobes, which are actually normal. We've also looked at things like changes in lung function during radiotherapy, and were we, I guess the driving idea here was, would we be able to pick up impending radiation pneumonitis? And so we took patients who are having their either breast or lung irradiated with significant irradiation to the, significant spill dose to the lungs as well. And so we got the treatment beams. We then divided the images up based on the amount of dose that would be delivered to the lung into these decile levels, as you can see here. And so this is sort of stepping through from the CT. Here's the dose fields. That's overlaid on the CT and overlaid on the lungs segmented from the CT. So that's the 50 grey area in white and so on, decreasing. And what we saw, if you concentrate on the red here for the ventilation and perfusion, after the irradiation, This is the lowest level of dose received in the lung actually took up more function, whereas the area that got the highest dose, greater than 50 gray, decreased its contribution at 3 months but bounced back when we got to 6 months. And we saw that on both ventilation and perfusion across a number of subjects. So we thought it was a reasonably sensitive technique for picking up changes in ventilation and perfusion due to radiation. And unfortunately for us in this study, no one went on to develop pneumonitis, so we couldn't really correlate that. So the advantage would be that you would use this to try and detect early changes and change the fields if you thought you were going to get anywhere near a level that would may compromise the patient. Lastly, I'll finish with just some of our exploration of PET scanning with VQ. It's not so new. In fact, this is from 1974. Dave Chesler from the Mass General Hospital group actually used gallium-68 microspheres to scan, this was a dog, I think. So it's been around for a long time. We just didn't rediscover this a few years ago. And I think some of the physics people in particular have known that gallium-68 being a generator-produced thing was really convenient to have in the lab when you were developing PET instrumentation. Today, of course, we can use it for both the MAA labelling as well as galley gas imaging, and it's incredibly simple to use. In fact, while I guess the cyclomedica people might suggest that to get an optimum burn of the galley gas and production, you might change some of the parameters, perhaps the temperature of the crucible and that. We, in fact, haven't changed anything, and it works incredibly well. So here's our radiosynthesis area where we just take the generator with the gallium and just milk it straight into here, and then that goes into the crucible and burns just like you would Technigas. And these are the quality of images that you get with PET. The advantages of PET are that it's fairly quick. You can gate the studies, which are much harder to do with a spec camera with multiple projections. And you can also gate the CT if you've got the software to do that in the acquisition system. So we've preferred to do galley gas scanning for research applications, and certainly if we were thinking of things that was just airways based, like asthma imaging and that, we would certainly be looking at using that PET for that. However, I couldn't see how you could possibly use this routinely in PE in a busy hospital where your PET scanner is doing lots of other FDG and other scans. So here's a 74-year-old female with COPD who's due to have radiotherapy. And what this study was looking at was, can the galley gas scan be used to define the best pathway for the beam so that we spare the normal lung, because she's already got obviously very compromised lung function. But even in the case of COPD, you can see you get really good images of the lungs where she is getting ventilation. So the potential advantages, you've got high signal and sensitivity, improved image quality, better spatial resolution inspect. The short half-life means you can do multiple scans at a single day. So perhaps in an asthma patient, you might do a baseline followed by a methacholine challenge, and you could do that one in the morning, one in the afternoon. Quantification in PET is obviously well established. Respiratory gating, as I mentioned, faster acquisitions, and I think there's lots of research applications for these, the galley gas and MAA combination. Michael Hoffman's been doing a fair bit of this at Peter Mac in the setting of PE, and very successfully. We've been, as I say, sticking more to research applications, and here's some of the stuff where we've been looking at, can we use the CT scan and a ventilation subtraction scan, and how does that correlate with the galley gas? So the idea would be there that you'd use your planning CT on the CT simulator, and you'd be able to actually come up with some estimate of ventilation based on the subtraction of end tidal breathing CT from full expiration. So that's how the things change with the use of the appropriate scan. Radiation dose is going to be higher from a PET study because it emits a particle, the beta positive positron, but still we can greatly reduce the dose, and so we can play that off against the increased radiation per decay and keep it still at a very low level, and typically under 5 millisieverts for that. So with that, I'll thank you very much. Thanks.
Thank you, Professor.
Thanks.
Dale.
Okay, thanks, Dale. So our final speaker, as you know, the US leads in so many areas of medicine. VQ is not one of those areas. So I thought I might just get an eminent and experienced person to give a bit of a US perspective, and also I guess what we've heard over the Saturday session and today, and just give a bit of a feeling about where he sees VQ going, particularly now that we're in the era of SPECT in the rest of the world and increasing CTPA. So Henry Royal is an eminent and experienced person from the Mallinckrodt Institute of Radiology, former president of the SNMMI. And so Henry, thank you for agreeing to the challenge that I gave you.
Okay. Well, thank you, Paul, for inviting me. I don't know if you know this or not, but I actually did do SPECT perfusion studies back in the mid-'80s. Unfortunately, we never had a good SPECT ventilation agent. I think all of you know that Technigas has never been approved for use in the United States. And if you look at just the perfusion study, this nice organ that looks nice and homogeneous when you look at it in planar imaging, when you look at it tomographically, it's not so homogeneous, and without a good ventilation agent, we weren't smart enough to figure out what we were supposed to be saying about it. In any case, I was going to describe what's been happening with VQ imaging in the United States, list some of the unique information which is available for VQ imaging. I've always actually been quite a proponent of VQ imaging. I think functional imaging is important and will always be important, and then talk a little bit about the future trends of VQ imaging. One of the committees I served on recently was this molybdenum-99M for medical imaging. The United States uses 50% of the world's technetium. And one of the concerns was, of course, that we don't produce any Moly-99 in the United States, and what our supply was going to be like. And I'll show you some information about VQ imaging from that report. In addition, this report 160 from the NCRP estimates what the radiation dose is to members of the population from medical imaging. And of course, in order to know that, you have to know what kind of test they're having, and there's some preliminary information about what's happened with VQ imaging over the years with that I'll share with you. So this is a image from the National Academy of Sciences report. That top line is Tech MAA, the blue line is Xenon 133, and the green line is Tech DTPA. And you can see there's been about a 30% decrease in MAA usage. It's interesting that it went down. I think it went down dramatically when CTPA was first introduced, and then there was a little concern about it being oversold, and the MAA use went back up, and now it's been going back down again. But about a 30% decrease in MAA use in the US. The NCRP report, the information is preliminary, but the numbers we have from 2004 are that there were almost 1 million MAA doses used in 2004, and it's dropped by about 100,000 in 2014. So despite the fact that there are many people who talk about VQ imaging being dead, it's still around. Unique information available for VQ imaging. I'm just going to talk very briefly about this. Clot burden, I think, is an important concept. When you die from a pulmonary embolism, you die from increased pulmonary vascular resistance, and is that better determined by CTPA, or is it better determined by VQ imaging? We'll talk a little bit about that. Right to left shunting and regional lung function, I'm not going to talk about, but those are obviously areas where VQ imaging can provide some information. So as I've said, what's best to predict the severity of embolization, pulmonary embolization? Is it going to be interluminal filling defects, which you see on pulmonary CTA, or regional perfusion abnormalities? I would say if your regional perfusion is not affected by the interluminal filling defect, it means that your body can keep up with that clot burden. It's really not affecting pulmonary vascular resistance, and that would have some prognostic significance. You'll notice that I've also listed on this slide about clot burden thrombus-specific agents. It's always been amazing to me that in the 1970s, when people were looking at perioperative DVT, we used a fibrinogen uptake test to sort of figure all of that out, a non-imaging test. It would be really nice to have an imaging agent that showed you active clot formation. Of course, I don't know how you could get our FDA to approve it, because if you have a test that provides unique information, it's very hard to have a reference standard to show that you're correct. This is an ex vivo cast of a pulmonary arterial system. Sort of shows you what the diagnostic challenge is when you do a pulmonary CTA. You're looking for interluminal filling defects that are a few millimeters in size, and there are lots of areas where they can be. And Diane has nicely gone over what some of the limitations are, as well as some of the benefits of pulmonary CTA. The first talk I went to on pulmonary CTA, I was sort of stunned by the fact that the person who was presenting the talk said that spiral CT tells the clinician exactly what they want to know. It's none of this probability stuff. It's yes, they have PE, and no, they don't have PE. And of course, when pulmonary CTAs were first introduced, they only did part of the chest. They didn't have the resolution they currently have. And his answer was, if we don't see it, it's not clinically significant. In contrast, when you look at regional pulmonary perfusion with a VQ study, rather than looking for the interluminal filling defect, you're looking for the ramifications of that, the decreased blood flow distal to it, and we're looking at segments that are centimeters in size. This is a perfusion study from 1985. I've always used it because I thought the basal segments were very nicely outlined here, where you have perfusion in this LPO view, and then you have absence there. One of the problems that we don't seem to talk a lot about is PIOPED and many other papers talk about perfusion defects, but there's lots of characteristics of perfusion defects that are important if you want to make the diagnosis of pulmonary embolism, and we need to talk more about those. So the question, I think this whole idea of a binary diagnosis of pulmonary embolism, I hope we can get beyond that. I think it's a very simplistic view of pulmonary embolism. Pulmonary embolism is just like any other disease. You have mild forms of it, and then you have life-threatening forms of it. And talking about severity of disease is very important. I don't know what it's like in your department, but in my department, people call up and want to know whether the study was positive or negative. They don't want to know anything about the extent of disease, and I think that's a real problem. So what are the dimensions of pulmonary embolism? What sort of factors should we be concerned about? Clot burden in the lung, I've already mentioned. Sources of future emboli. So you really need to know what's going on in the legs. The illness of the patient. Patients with underlying cardiopulmonary disease are not going to do as well as people with who are otherwise healthy. Risk of anticoagulants in that particular patient. So whether or not pulmonary embolism is significant and needs to be treated depends not just on the imaging result, it depends on many other factors. And just to show you a slide of something that you would not have otherwise known about if you didn't do a VQ study, here's a patient who is not ventilating their left lung, but they're perfusing their left lung, so they have a reverse ventilation perfusion mismatch, which clearly explains their hypoxia. The management of this patient is totally different than the management of someone who's hypoxic from pulmonary embolism. This person had bronchoscopy and had a mucus plug involving his left mainstem bronchus. Okay, so let's talk about future trends for VQ imaging. We've heard a bit about radiation dose, and that somehow is a factor in deciding whether to do VQ or a pulmonary CTA. I think that's really being oversold. Jeff showed a slide where he had mentioned what the lung dose was and also what the lung mortality is. And the lung mortality is much higher than it is for the breast cancer, and we don't seem to talk about the lung dose. And the lung dose is similar in VQ imaging and in pulmonary CTA, and it wouldn't take much of a lowering of the pulmonary CTA dose to make pulmonary CTA be the diagnostic modality of choice if you look at lung cancer deaths as opposed to breast cancer deaths. So I think going down that path and saying we ought to be doing VQ studies because of radiation dose isn't really going to get us anywhere. I've heard a number of people stand here and talk about the usefulness of SPECT and SPECT-CT, and I want to talk a little bit more about how we evaluate usefulness, and I also want to talk about probability. So that's where I'm going. So when I think about usefulness and when I think about that I'm going to try to convince someone that something that I'm doing is useful, I think of these levels of efficacy or a hierarchy of efficacies. So the first level is technical. In technical would be, I have a CT scanner that has better resolution than another CT scanner, and I say, you know what? This is going to be better for patients because it has better resolution. And when you look at SPECT versus planar imaging, the resolution is actually worse with SPECT imaging, but the contrast resolution is much better, and obviously being able to localize where the defect is better. But that's sort of the lowest level of, does this really help patients? The next level is diagnostic accuracy, and I want to talk a little bit about diagnostic accuracy because I've heard the words sensitivity and specificity mentioned an awful lot in the 2 sessions that I've gone to. So sensitivity and specificity really reduce very complicated things into binary results. You have a binary result for the test result, and you also have a binary result for the disease status. So you know nothing about severity of disease, and you only know whether the test is positive or negative. I think that's really a disservice to complicated tests like imaging test results, because there's a lot of features in the images that provide useful information that get lost when you just do positive and negative. To make diagnostic accuracy even worse, typically the way we do diagnostic accuracy is by comparing the test of one imperfect test, the results of one imperfect test with the test of results of another imperfect test. I've heard the words that sensitivity was 95% or 100%. That assumes that you know what the actual disease status of the patient is in order to have that kind of high sensitivity. And I don't know what that reference standard is that people are using. I think, clinically we don't know. We don't know at what point pulmonary emboli become clinically significant. So when I hear sensitivity and specificity, I think not interesting. So when I think of the results of imaging tests, I think they come on a spectrum. They go from definitely normal to definitely abnormal. In the VQ world, we divide them up into these little boxes. We divide them up into normal, low, intermediate, and high. And we put these little artificial lines here to break up the boxes. And that affects our opinion about observer variability, because if observer A says this is a low study and observer B says it's a low study and they're this far apart on this continuum, we say they agree. But then poor observer C comes along and he very much agrees with B, much more so than with A, but we say they disagree because he just happens to be on the other side of the line. So I'm not in favor of binary results in VQ imaging. I don't think that that's the real world. I think we're just kidding ourselves in losing a lot of information by using binary results. So what am I in favor of? I kind of like patient outcome. I'd like to know that if you add a diagnostic test to a patient, that it's somehow going to make a difference in their outcome. Do they get out of the hospital quicker? Does it cost them less money? Are they happier with the care they received? You got to show me something that this test did some good, something that's meaningful to the patient. So I'll show you, a few things about patient outcome. Pulmonary arteriography, when it was introduced, there was no reference standard. It was its own reference standard. I always wish that I could have tests that were their own reference standard. But one of the things that they did know about pulmonary arteriography is that if they didn't anticoagulate people with negative pulmonary arteriograms, that those patients had a low subsequent thromboembolic event rate. So it was with follow-up studies that they would say, okay, it's safe not to anticoagulate someone who's got a negative pulmonary arteriogram. That's somewhat surprising given what we know about pulmonary embolism these days, because they didn't look at the legs at all, and you'd think that knowing what was going on in the legs would also be an important part of all of that. I would point out, however, that with pulmonary arteriography, if you look at the PIOPED study and that was published in JAMA in 1990, that the observer variability for a negative study was 15%. So what that means is that if the consensus reading was negative, and then you just gave the pulmonary arteriogram to someone who didn't know what the consensus reading was, that 85% of the time they would agree. It was negative 15% of the time they wouldn't agree. So you can imagine if you were doing sensitivity and specificity, I mean, the idea that you're going to do sensitivity and specificity and get something that's better than what observers would read the same study as it just doesn't make any sense to me. So there is one patient outcome study that I like to talk about all the time, and that's the Wells study that was published a long time ago now, 20 years ago, believe it or not. And it was, how the Wells criteria was developed. And they looked at three things. They looked at pretest probability, VQ results, and then serial ultrasound. And remarkably, if you had a non-high, so an intermediate or a low VQ study, a low or moderate pretest probability, in normal serial compression ultrasounds, the subsequent pulmonary embolic event rate was 0.5%, so similar to what a negative pulmonary arteriogram was. And what they argued was that if we accept a negative pulmonary arteriogram as good enough evidence not to anticoagulate someone, why wouldn't we accept these other tests? And so patient outcome studies is really what we should be doing today. We should not be doing any more diagnostic accuracy studies. I don't want to hear the word sensitivity and specificity ever again. Okay, I'm going to end by talking about probability. And I know that there are some people in this room, Paul, who don't want to talk about probability. This is a graph that I made up from the 1990 Pioped paper. In the 1990 Pioped paper, they didn't do any sort of formal pretest probability. They did some gestalt assessment of how likely the clinician thought it was that they might have PE. And the clinician said they had to pick 0 to 19%, 20 to 79%, 80 to 100%. And then, so on this graph, what you see is the VQ result, imaging result on the x-axis, and then the different color bars depend on what the clinician gestalt was about how likely it was that they had PE. Why you would want to throw out this data, I don't know. You can see that somebody who has a low VQ result in the Pioped study has a higher subsequent proof that they had PE than someone with an intermediate result who had a low in moderate pretest probability of disease. So I think knowing what the pretest probability is, combining it with the test result, and using probabilities is the way the real world is. So what do I think we should be doing in the future? I think we should be getting rid of simple platitudes. We have way too many of them with PE, and many of them are conflicting. Recognize the complexity of PE, and then I'll say a few words about SPECT and SPECT-CT. So here are some of the simple platitudes. Every patient with an intermediate VQ results needs to get a pulmonary arteriogram or now a spiral CT. I can tell you that back in the day when we were doing pulmonary arteriograms, we looked to see how many of our patients who we read as intermediate VQ results went on to get a pulmonary arteriogram, and it was 14%. So, you look at all the algorithms, and all the algorithms say, pulmonary arteriogram, pulmonary arteriogram, pulmonary arteriogram, but that's not what happens in the real world. So we say a lot of things that we really don't mean. PE is underdiagnosed. You hear about all the autopsy studies and all the people who are found with PE at autopsy, that it's overdiagnosed, that it's a killer. The whole thing about it being a killer comes from Barrett and Jordan back in 1960 when heparin first came out, and they said, what are we going to use heparin for? And they said, hey, let's use it for PE. That sounds like a good thing to use it for. And the study was that they randomized people to get heparin and no heparin, and 30% of the people who got heparin, 30% of the people who didn't get heparin died, and 8% of the people who got heparin didn't die. And so they said it's unethical. Matter of fact, they stopped doing the study before they intended to stop doing the study because they said it's unethical to withhold anticoagulants for someone who's got PE. Well, what's the problem? The problem is that back then they had no pulmonary arteriograms. They had no VQ studies. The diagnosis of pulmonary embolism was based solely on clinical findings. These people had massive pulmonary embolism, but that sort of resulted in the whole idea that if you have PE and you don't treat it, it's unethical. We also hear some PE are not clinically significant, and then PE is a binary diagnosis. We shouldn't talk about severity. So I think if we were to acknowledge the complexity of medicine, we wouldn't talk about binary diagnosis, we'd optimize our ability to do probabilities, and we'd recognize that patient management really depends on many factors than just the imaging results. And then the last thing about VQ, SPECT CT. So if we ever get a good ventilation agent for SPECT CT or SPECT, I think we probably would do SPECT, and I'm optimistic that we will get a good ventilation agent sometime in my lifetime. And then the question is, should we do it on everyone or should we do it on selected people? To be honest, I mean, I think it's actually simpler to do it on everyone, because the minute you have put a decision tree in the flow of patients, somebody has to sit down and figure out what's going on. It's just easier just to go ahead and do it. There's this concept of marginal cost effectiveness, which I don't have time to explain, but there's diminishing returns with each step along the way where we add more and more diagnostic tests, and it's a real big problem in medicine because medicine ends up being very costly because we keep adding and adding and adding stuff. Do we really want increased sensitivity? I'm not so sure. Increased specificity probably would be useful. Other diagnoses, I think a lot of times the other diagnoses are either unimportant or already known. So I hope that I've convinced you that, when you ask the question, does the patient have pulmonary embolism, it requires something more simple than just a black and white answer. There's really a lot of nuances, and it's really not just a yes and no answer. By the way, if you'd like a copy of these slides, send me an email and I'll send you a PDF. Thank you very much.
Well, I was keen to get something thought-provoking to close the program. I think you've done that for us. So one of my respiratory physicians once said, the more I learn about PE, the more I try and get my head around it, the more complex it all seems. And I think you've covered a bit of that. Look, we've covered a lot in the last two sessions. Thank you very much to all of our speakers, especially Henry. If you have questions for him, you can follow him to his taxi and chat all the way to the airport. Otherwise, the other speakers are up the front. Thanks very much.